I think something which is gives goosebumps to me. शुरू में जब when somebody used to tell me that कि मेरे से मिलने आना है, I used to tell MGM आ जाओ, तो most of the people used to land up in MGM hospital, वाशी, मुंबई. तो बॉम्बे पहुंच के बोलते थे सर मैं पहुंच गया, कहाँ मिलना है? तो मैंने बोला यार मैं तो चेन्नई में हूँ. तो चेन्नई में कब से MGM खुल गया? तो MGM is such a widely used brand. From roads to buildings to everything is MGM. Mahatma Gandhi हर जगह है, तो that name is widespread. And unfortunately, because of this brand to become visible across the country, we had to do something which is quite unnatural. So that's where our story starts actually. And we started in the year 2019. And I wish I could show some videos and show it to you how the hospital looks for the people who have not seen the place. There are many people in the crowd who have seen the hospital, and I'm thankful for them to visit our hospital. It's a very tastefully and beautifully done hospital, and it is a modern hospital in all aspects. And what COVID threw to us, because when we started it was July, and COVID came in the month of December, and what we saw was absolute mayhem, and people with 20 years of healthcare running experience and people who have just come into healthcare were all equal. So I always say that COVID was a big equalizer in the industry. The reason is that I think the whole customer base changed, a lot of things changed. But as you say, I think, when the going gets tough and the tough gets going, and that's what happened with us, because we didn't have any baggages. We had a fairly young crowd, a new team, no baggages to carry, so whatever came our way, we just took it up. And it was a nimble beginning for us, and we got it googly from the first ball itself to say, and here comes COVID, and we have to adjust appropriately. But we shut down the hospital and didn't take COVID for almost like 6 to 7 months. The first wave almost we skipped. We thought we will not get into it. We didn't want to become a COVID hospital, so to say. But then came the big news. I think all of you know about S.P. Balasubramanian, the singer legend by himself in all rights. And when he got COVID and he wanted to get some place, he wanted to be in our hospital. So that's when we took a conscious decision that I think we should go ahead and take it, because now there is a dire need. Big people are falling sick. It's not that I'm trying to discard the other part of it, but we were trying to think what the time to get into it when we can actually make some meaningful contribution to this whole pandemic. And when this started happening, I think when SPB's case happened, that is when the second wave was just about to start, and there were no beds available in the city. Then we just said, okay, let's open the doors. Let's not be now, conservative about this whole approach. And SPB's story turned out to be a big thing in the industry because of two reasons. One, he himself being a legend and a celebrity, and he was one of the biggest celebrities who got COVID. Second, which made the industry look up to during that time, was ECMO. Nobody heard about ECMO till then, till Mr. SPB went on ECMO. Unfortunately, he couldn't make it. We still regret. We always hope that he could have made it. He just slipped at the last moment. But whatever we could do, and his son was so grateful to us for doing whatever is possible. But one thing, I think great people leave great legacies. Apart from his great voice, I think he made a great education to people about the utility of ECMO, which was in the industry for almost like 20 years. And Dr. Bala and team were doing ECMO for almost like 15 odd years in India, but nobody knew about it. But when it happened to a celebrity like him, everybody woke up to ECMO, and there is a therapeutic application on COVID times. It was very, very visible, and it started becoming banned. Everybody started talking about ECMO. And at one point in time, I think I could realize that there was few centers. I think we did a count at that point in time in India, and we found that in every medical college there is an ECMO line for more than 5 to 10 years, unutilized, and people started dusting it, taking it out कि भाई इसको इस्तेमाल करना है कल से, क्योंकि ECMO use कर सकते हैं COVID में, because it is extracorporeal support. But they didn't know how to use it, so that becomes a challenge. Then comes the situation that ECMO कितने का आता है? People didn't even know how much it was. I think then it came around 15-20 lakhs for one kit to be got in. That was a huge investment to do for a short-term period, which doesn't have a long-term, ROI when it comes to an hospital point of view. So who will do this? Many hospitals were having cold feet in terms of doing this. Would you believe that we were running probably the world's third largest ECMO program during that time? We bought almost 25 ECMOs, and I was running the largest ECMO program in the entire Southeast Asia at that time. I had 25 patients on ECMO, and that was the largest. I think I converted overnight almost 25 beds to run only ECMOs. And during that period, few more things happened. Is that we became the largest utilizer of air ambulance in India. And the air transfer to my hospital was almost every alternate day from every part of India and abroad. Even I shifted a patient on ECMO from Nairobi, which is a record by itself, by changing 2 flights. So there's some of the extraordinary work the team has done, and that's primarily, I think, just now Abhik was mentioning, I think you've got some jewels in the hospital. So brick and mortar anybody can create. I think it's very easy to do so. But finding the right talent and the great talent to work with is something which is probably very difficult to get, and that's where it goes through. We basically come from an education background. Our genesis comes from last 25 years. We've been a medical education company. We are not a found private healthcare partner business actually. We started this business in the last 4 years. But our genesis, our background is education. We run 2 medical schools, one in Pondicherry, another one in Chennai. We also run allied health schools, allied health like nursing, paramedics and all, we run it. We also have our own schools. We run 8 to 10 schools in Chennai. Now our newest interest is to get into private healthcare. And we are not into a race, so to say. Because of coming from an education background, our primary interest is to create great clinical programs, which I think people can swear upon. People can actually, say that, okay, if there is something like this, that's the institution. So to refer to a parlance, I would say, we would like to be the Cleveland of India. Anything or anything is, if you want to do something great, complex, high-end work, look up to that institution. Because that's the way we are building it. We are building for the next 5 years, 10 years, and investing into clinical programs, which is kind of way ahead of its time. So when I say that, I make, in true sense, we are trying to do that. Because with Dr. Bala and team is a heart and lung program. We have started our liver program almost 2 years back. We already had a kidney transplant program, but today you will see a completely new dimension to kidney transplant and how it can be seen in a different viewpoint by Dr. Vaidya. And Dr. Vaidya is, how do I say, I think I've been chasing him for almost like 5 to 6 years. And he is a legend in his own rights. And we as an institution are very fortunate to have him with us and partner with him to start a program which is so unique in its own nature that nobody else can do it in the entire South of Asia. Different. All these, what we are trying to do is beyond routine patient management, patient care, business development, and so on and so forth. These are something which we are trying to do to ensure that when we reflect back after 10 years, I think people should say that, hey, this institution contributed not only just by treating patients, but to the entire ecosystem of healthcare by bringing in things which probably none other than nobody else thought about. So I think that's a classic example of forward and backward integration in pure business parlance when I say that. So I think a true institution should actually look at it in that form. You should not be looking at forward, you should actually see backward, also see how you can integrate things, bring costs down, see how it can actually benefit the end customer. So that's about our organ transplant from a heart and lung point of view. I would like to just spend another 5 minutes. Since the screen is up, I won't eat up much of your time because they are the showstoppers today, so I don't want to talk much about it.
Before that, I would like to welcome the legend of multivisceral organ transplant, Dr. Anil Vaidya. May I request Mr. Avik Moitra to present a bouquet to Dr. Anil Vaidya and take him to the dais. I request for
कोई और भी उठा लो फोन है इतने सारे। हाँ सर।
he has a big profile, but still I want to say a few words about him to give an introduction about Dr. Anil Vaidya. Dr. Anil Vaidya is a multi-organ transplant surgeon. He did his general surgery in India and specialization in urology in UK, followed by fellowship in urology oncology at Miami. He has a significant contribution to the development of pancreas, intestinal and multivisceral transplant programs. He remains one of the few surgeons in the world who has done over 1,000 pancreas transplants. His lifetime goal is to promote a world that is free of diabetes by the year 2030 and free of dialysis by the year 2050. He is also actively involved in research to improve transplantation outcomes and to develop new technologies in the field. A few recognitions about him. He holds the largest series of cases of abdominal wall transplant. He is the first surgeon in the world to introduce the concept of nephron-sparing auto-transplantation for solitary kidneys with tumors. He is the most experienced surgeon in the world in pancreatic transplantation with more than 1,000 cases to his credit. He has conceptualized and helped in executing the first ever vascularized facial nerve transplant in the world for a patient that was already on immunosuppression for an intestinal transplant. This is few words about him. The more you will know when he comes on the dais and gives his talk. May I request Dr. Anil Vaidya to come on the dais and give his presentation.
Thank you for that introduction. It was a bit elaborate, but I'm really happy to be here. I'm very, very happy to be part of MGM Healthcare. They're perhaps one of the youngest but fastest growing healthcare platforms in India today, and very, very happy to be part of that growth. What you're going to hear today is the why, what, how of unique transplantation at MGM Healthcare. Now, why did I choose why, what, and how? This is based on our evolution as humans from primates. Our brains evolved, and our brains, if you see it, has three concentric regions. The innermost region is the limbic system that constantly asks the question, why? Why am I doing this? This is emotional based. Why am I doing what I'm doing? This next concentric circle is, what am I doing? Why am I doing this? You rationalize and say, what am I doing? And the third neocortex says how I do it. So most of us have that gut feeling. The gut feeling comes from the inner circle. And then as humans, unfortunately, we've been able to rationalize and give language to that gut feeling. And when we start something because of passion, because we think that this is something that we like to do, we quickly are able to talk ourselves out of it. And that's the beauty of being human. The gut feeling, the inner core, the why we do things, is lost because of the ability for us to give language to that thought and talk ourselves out of it. An adult kidney into these small kids and how they do. So kidney transplantation in small kids is going to be touched on by Dr. Dinesh, who's our intensivist and anesthetist, because my work is nothing unless he's on my side. These kids require such amazing amount of attention, and it's not only surgical, but it's also medical management. So Dr. Dinesh is going to talk about that. In my journey through transplantation in India, I have met Dr. Senthil, who's an extraordinary surgeon, and has taken up the mantle of taking that gift forward to try and bring a cure for diabetes in India through pancreas transplantation. And he's going to talk about pancreas transplantation. The last but not the least, I'm going to talk about my work with intestinal transplants for cancers. Mind you, when I first did this 10 years ago, I was criticized by a lot of people, but now it's become the norm. People invite me to give talks on this topic. So, come back to that point. The limbic system tells you something. Your neocortex, which is our humans who progressed or evolved from primates, talks us out of our gut feeling. And we're going to try and refuse to be talked out of our gut feeling. With that, I'll just start this. The why. Why should we be doing this? I think we are positioned well because we've got a dedicated transplant team consisting of world-renowned surgical expertise, the only anesthetic team in the country and region with experience with all abdominal organ transplants. There are sectors where you do only liver transplants, people only do kidney transplants, and they get their expertise in each one. But our team, led by Dr. Dinesh, is an expert in all the organs, and each and every organ has its own nuance. We're very passionate about our work ethic. We're very patient-centric. We try to connect with the patient and their problems. The patient's problems are our problems, and that's what we like to project. We are very self-critical. We try to make sure that our data drives our outcomes. We have, every quarterly we look at our data and make sure that we are on international standards for our outcomes. And over the years, we've had some very unique interventions that have made things like intestinal transplants a reality. If you say intestinal transplants now in the Western world, they say, yeah, we can do it. But we started that in India, a country where the bioburden is about 6 times the Western world. With intestinal transplants, these patients have lost their intestines, so they can't eat or drink anything. They have to be maintained on exogenous nutrition called TPN. That needs a line, and these lines get infected very quickly. A line change could easily set you back 50, 60,000 rupees. And if that happens twice a week or twice a month, that in itself is a huge cost burden. So the interventions that we put in with the support of MGM healthcare has allowed us to bring down the infection rate, which was at about 400 infections per 1,000 catheter days, to 0.3 infections per 1,000 catheter days by very simple interventions and teaching the patients. So now we have patients waiting for intestinal transplant, not in the hospital. They're waiting outside the hospital because we've taught them how to take care of that line, how much nutrition needs to go in. We cycle them to 12 hours of nutrition. For 12 hours in daytime, they're without that nutrition. They don't need it, but they got all the nutrition in the night when they're asleep. So they're mobile, they're not stuck to a pole. So this is the paradigm shift that we're seeing in the build-up to have a platform to do intestinal transplant safely. As I said, the what that we do pediatric kidney transplant, and we're going to concentrate on really small kids. Pancreas transplants to cure diabetes, and intestinal transplants for cancer, which are
transplant in MGM. So now, today with this topic is pediatric kidney transplant. This is the heart of the topic for Dr. Vaidya. He always used to talk about pediatric kidneys. I was surprised, why did he give me this topic? He could have given anything else. Why did he give me this? He always used to quote something saying, boss, kidney transplant is a low-hanging fruit. And for the 8 years I've been associated with him, I still didn't recognize, what do you mean by low-hanging fruit? Low-hanging fruit. Yes, everybody does it. The low-hanging fruit has been picked up by everyone. So what do you think by it? Then when we introduced him to the pediatric transplants and things, they said, boss, still a low-hanging fruit. How well you pick it up is what we do. He keeps telling us how well we do it. Everybody does kidney transplants, everybody does things, every nook and corner of the hospitals in the streets, and everywhere they do a kidney transplant. But what we do is something different from what others do. That's what keeps us the thing. That's the reason why when he says low-hanging fruit, I say, boss, it's not low-hanging fruit. When you see the pediatrics, then you will understand it is not a low-hanging fruit. So, what is the need for the
next slide.
see the pediatric transplants in India? It's very, very low centers which do pediatric transplants in India, pediatric kidney transplants, which I report. Out of which, even the smaller kids, I don't think we have seen less than 10 kg child having an adult kidney putting into the abdomen. The abdomen is so small, you have to put a big size adult kidney into the abdomen. It's a very, very challenging surgery for the So internationally, 1 in 65,000 kids have this end-stage renal disease needing dialysis. So why is there a need? Renal failure in children, as we say, there are many familial syndromes like Alport's, and some are not familial. So when they progress into an end-stage renal disease, is most dangerous of all and can hinder a child. When you see the kids coming, 15-year-old, 14-year-old will be only one short coming without, all with growth retardation and all those things, failure to thrive with on dialysis. So when you see them, you become more disheartened to see, 15-year-old and still short and thing. So why is that important? Why is that early transplant is important? And just a dialysis is not going to suffice for them. So in small kids, especially in small kids, but in pediatrics, though combination of dialysis is not a good thing, especially in small kids when they don't have access. The access is very, very difficult. They have very small access. You cannot have them on hemodialysis. You need to put them on a peritoneal dialysis. And when you put them on a peritoneal dialysis, you have another complications of having catheter infection, pain, discomfort, and all those things when they go up. So when you identify such kids, like less than let's say that 1-year-old child or a 2-year-old child having this sort of symptoms on dialysis. Now, initially people used to say, no, let him grow up to 20 kg, we'll do a transplant. Now they don't grow. Even after 15 years, they say, you see, 18, they'll be less than 18 kg. I used to ask the nephrologist, when will they grow? They don't grow. That's when Dr. Vaidya used to tell, no, they need to be put on early transplantation for them to have a longer, better thing. So they may require multiple transplants because when they take up a cadaver transplants, if they go on a cadaver transplant, the life of a cadaver transplant do not last more than say 7 or 8 years. But by the time they grow, they may require a lot of other transplants. So the other challenging thing in this is placing an adult kidney, it's a big size kidney, into a smaller abdomen. And there are a lot of fluid shift happening, which are of the most important thing in the thing is they connect everything and they put it on the ICU and say, boss, you take care of it and go. And that's when we get into the place and say, boss, how do I give 15 liters of fluid for a 10 kg child? And that child is peeing after your kidney like close to around 15 liters per day. So all this is very, very immense challenging with the pediatric transplants. Previously mentioned is a very, very important part. When you list them for a cadaveric transplant, they either need to wait a long time for them to get an organ, and after you have given them a cadaveric transplant, the half-life of the kidney is just 5 to 7 years. But whereas when they have a living donor, there's no waiting time, and the half-life is close to around 25 years. So by that, you cut short the.
So let me just explain half-life. Half-life is 100 cases this year. In how many years will half of them still be working? So in a cadaveric transplant, unfortunately, it's only about 5 to 7 years. So if you're going to transplant a cadaveric kidney into a young child, there's a good chance he's going to be needing another transplant. He'll be needing another transplant. 50% chance he's going to need another transplant in 5 to 7 years. So the choice of the source of organ is very important here. If you have a pediatric patient requiring dialysis, this patient should have a live donor option. And usually kids have that. Their parents are there, their aunts are there. It's a very close-knit family when a child in your family is ill. So this is a very important slide here. This is one that you should be trying to get these people away from cadaveric transplants and going for live donor transplants. How to give all the data we've accumulated over the years to give them an anti-rejection drug, which is called Campath or elentuximab. Now Campath was developed in Oxford and Cambridge in the late 90s. And there is a thought that Campath is very, very powerful. And the kids, if you give Campath to kids, it's like a neutron bomb. But it isn't. If you know how to use it, it isn't. If you know what the dose should be. We've done a study in India where we now give one fourth the Western dose to our kids here. And they do extremely well. So we do not have any rejection. We're not seeing any rejection. In fact, our rejection rates are the lowest in the country. The recurrence of original disease is a problem. Again, our team is used to that, and we have pediatric nephrologists who trained at the Great Ormond Street renal units. They're part of our team, and this is what makes our team unique. We make sure that these patients are followed up and make sure that the recurrence of their original disease is preemptively treated after a transplant. Compliance is a huge issue with kids. If you are into transplanting kids and you do not understand compliance, you should not be transplanting kids, because these kids are going to grow. And when they grow, they become teens. And we all know what teens do. They take things in their own hands, and they want to be able to control their lives. And sometimes they stop taking their medications. But what we've developed is a transition program with psychologists to take them from their teenage years through college and bring them onto the adult side. If you don't have that, you should not be dealing with pediatric kidney transplant, or rather any transplant. You have to have that support from social work to be able to take them through a transition, and that's where compliance comes in. You keep a tab on them. You just don't let them go.
Even a week back, we had a sub 10 kg child, 8.5 kg child, and proper mapping of size mismatch through 3D printing, which Dr. Vaidya would just after this slide will tell you about this, and the effective methods of pain control, which is my area. I take care of people, and proper psychological assessment and pediatric remote monitoring program. This pediatric remote monitoring program, our team does it quite differently with regards to the other team. So that's why we have a longer success rate for our transplants in our team.
I think what you highlighted, effective methods of pain control is important. In fact, we transplanted a sub 10 kilogram kidney, but after that we did a pediatric intestinal transplant, and the kid is out of bed with no pain. The interventions like tap blocks and epidurals is freely used, caudal blocks. So this is another USP. We do not like to have kids screaming around in pain. And our pain team, run by Dr. Dinesh, is superb in managing that.
And access to end-to-end solutions from pediatric dialysis to transplant and post-operative care with a dedicated pediatric hospital. And with low rejection rate, as we said, with the CAMPAT, you don't see rejections. I personally haven't seen rejection for close to around 300 adult transplants where we have used the same CAMPAT, and including kidney pancreases and pancreas transplants. And with low infection rates, the policies which we follow, the line care and all those things, the ICUs which we follow, and the experienced surgeon who has created 2 world-class international pediatric programs. With them, like as I told, his experience when I went to Miami, like close to six years back, they still used to remember Dr. Anil there. He was an alumni from there, and then they used to tell me, Anil, yeah. So he used to be so dynamic with the pediatric transplants there. That's all.
So I'm going to just allude to this technical, or 2 slides, 2 or 3 slides. So this is an example of how difficult it can get. So here we see, I don't have a pointer, but we used, so the kid had no veins. You couldn't put the kidney in. So we used the donor's right ovarian and right saphenous veins, so it onto the renal vein to use it as a vein graft. And this is a 10-year-old boy. Again, the same thing, ovarian vein used as venous graft between the renal vein and the splenic vein. Now this kid, usually we put the kidney onto the inferior vena cava. This kid didn't have an inferior vena cava, so had been refused a transplant at all centers. So we brought him in and we reconstructed his renal vein, extended it by taking a vein from the donor, the same donor, and put it onto his portal system. The splenic vein is his portal system, perhaps the first time in the world. This is important to understand, and as you flick through the presentation, you're looking at, I'm asking you to look at A4V4. Now A4V4, that means there are no vessels in that kid. He doesn't have an aorta, he's got collaterals for an aorta, and has no inferior vena cava. He's got collaterals taking the blood back to his heart. That's the slide showing no IVC, and that's the slide showing no aorta. Next slide. That's the one we are highlighting. Next slide. Next slide. This kid, no one in the world will take care of this kid. No one. Next slide. So we did we did reconstruction outside the body using 3D printing, using his images, CT scan images, and we created a model outside the body. This is trying to, have a platform so we can do this transplant safely. We don't want to just try it. We simulated it outside the body. And this is what we got. This was the 3D printed model we got outside the body, and we knew exactly where that kidney is going to fit. And that's the child on your left side, and that's the child that's grown up. No one would have done that.
So this is why he.
Asked a question related to the same things. When you say that we will also take the veins from which has already reached a maturity,
Yes.
and then the body will support that
Support
growth
that
again.
growth again, yes. Because of the growth hormone that the child needs.
And that's why they say in a pediatric transplant, the early you transplant, things are repeated dialysis line, catheterization of repeated dialysis line, and you have a big clot sitting over it. And that clot completely uproots your vena cava, and the flow to the
So that doesn't matter in kidneys. The only reflection is what he alluded to, 15 liters of fluid to a less than 10 kilogram child. You need the guts to give that fluid. If you don't give that fluid, then that kidney is going to thrombose. So which is why his team monitors the kid on a half-hourly basis and replaces fluid accordingly. This phenomenon settles down. We don't know why, but settles down within 48 to 72 hours. And the kidney transplant auto-regulates and comes back down to normal. It's miraculous.
And sir, what is the success rate? Your experience?
For pediatric kidney, we have 100% success rate. Within the last 7 weeks.
Sir, any specific
High sugars and low sugars. So if you have low sugars, what you need is glucagon coming into the system and balancing out your sugars. It's not just high sugars and insulin. And that's where I think we've gone wrong all these years. We've been treating high sugars. And even the pumps that have come now, the Medtronic pump, which is a closed loop system, not everyone is very satisfied with that pump because it does secrete only insulin. Medtronic now is trying to get a glucagon-derived pump also. That means you have a continuous glucose monitor. If your sugars go down, automatically the glucose gets secreted by the liver because of glucagon being secreted. What the pancreas does, pancreas transplant does, it corrects that. That's the beauty of the pancreas transplant. If you look at islet cell transplant, that's cellular therapy, it does that to a certain extent, but we're not yet there in the longevity of the islet cell. So pancreas transplantation right now is the only way you can actually restore or cure diabetes, be it type 1 and some type 2.
To overcome the diabetic control problem, and there's a marked improvement in quality of life. If you come across some pancreas transplant patient, they definitely feel they're like a new life and there's no prick every day, and they feel really better quality of life. And long term, obviously, secondary complication due to diabetes or very less. So whom do we recommend this operation? So majority of them are type 1 diabetes and very selected type 2 diabetes who has an insulin deficiency and not insulin resistance. And the patient with diabetes, as I previously told, they are more prone for blindness, kidney disease and other heart problems. As we discussed, the life expectancy of a diabetes patient is almost 1/3 less than the general population. So these diabetes and renal failure is almost hand in hand. Particularly the patient who has renal failure due to diabetes has a lot of other complications. Managing a patient diabetes with renal failure and non-diabetic renal failure is a lot of different, because these diabetes, because of this microvasculopathy, they have very difficult vascular access. Majority of vessels are calcified, so there are a lot of chances of thrombosis of AV fistula, multiple AV fistula, and even in lines with the diabetes like central line or perm cap, there's a lot of infections, and they have higher incidence of thrombotic even, and there are almost 12% mortality on waiting on a transplant list, particularly for a cadaver transplant. So, and there was outcome if we do only the kidney transplant, because we are not cured the primary disease. The new grafted kidney also will get affected by the diabetes. So when you do both combined, like simultaneous pancreas and kidney transplant, you are able to cure the primary problem and the complication of the primary problem. So that's the main thing for a simultaneous pancreas kidney transplant, so that we can protect the graft, and the graft life will be more when compared to doing a kidney transplant alone. And the median lifespan of these patients are about 8 years on dialysis. So when we do isolated pancreas transplant, so previously we were discussing about patient who has a renal failure due to diabetes, like particularly type 1 or specific type 2. There are a small group of patients like type 1 diabetes who has a hypoglycemic unawareness, or they have just started damaging the end organs, like early stages of nephropathy, early stages of retinopathy. These patients will definitely benefit from an isolated transplant. And the main advantage of this is, after a proper glycemic control, these early damage can get reverted, and that is by evidence in following slide we will see. So at the early stage, even before they go for end organ damage, particularly in kidney, if we do isolated pancreas transplant, we are able to save this patient from unnecessary kidney transplant also.
And it's important to know what hypoglycemic unawareness means. This is the patient who's been diabetic, has lost the ability to have that feeling when sugars are going low. And they're just fallen unconscious. They're not only risk to themselves, but the risk to the general population also. So these people are most often at home. They don't want to go out. They're in a room at home because they've got hypoglycemic unawareness. And a pancreas transplant will cure that. Not only normalize their sugars, but will restore back this whole hypoglycemic awareness. They don't need that because they've got a beautiful glucagon feedback once you have a pancreas transplant. But these people are crippled and are at home just because they cannot predict when their sugars are going to drop low.
And kidney transplant, there is a majority, almost 80%. Pancreas after kidney transplant, was underwent a successful kidney transplant in the past and struggling with diabetes, first diabetes. These patients come for secondary pancreas. This contribute a very small population. Pancreas alone transplant is explained for severe life-threatening complication of diabetes, mainly hypoglycemic unawareness. And subtype other things are islet after kidney, like similar to a pancreas after kidney, and islet cell transplant, similar to a pancreas transplant. So, as I told, there is some evidence for pancreas transplant with kidney. So, if you see this glomerular basement membrane, patient was underwent kidney transplant alone. On follow-up, if you do a biopsy, there is almost 50% of these kidney get affected by the diabetes. But if you see this SPK, simultaneous pancreas kidney transplant, almost only 7% damage is there. So by transplanting both organ in a patient who really needed it, so we are able to preserve the graft for a long time. And the normal relative mesangial volume is very less when you say kidney alone transplant. There's a lot of volume loss, and when we see this simultaneous pancreas, we're able to preserve the new graft also. And as I told previously, when you do a pancreas alone transplant in a patient who has just started the end organ damage, we are able to reverse the diabetic nephropathy, reversal of lesion of diabetic retinopathy after a pancreas transplant.
So the importance is early referral. when you start to have drop in protein in the urine as a diabetic, you get microbes in kidney to the patient. If it is a outside the hospital donor, the chance, no one's accepting the pancreas because no one's doing that. So we get the pancreas, but we may not get the kidney with the pancreas. So we've devised another way of doing this, is if there's a living donor option in the family, so we do a simultaneous living donor kidney and a cadaveric pancreas. So that's a way to overcome the fact that you may not get the kidney coming from the outside hospital. If you're doing only an isolated pancreases are available. Then it becomes a choice, which is a good graft. We don't want to put in a fatty graft. We need to have a very slim graft that has no pancreatitis after you've transplanted.
So there are a lot of type 1 patients across the country. The awareness of this program definitely is not there. For me, it is new. I knew that there is a doctor called Dr. Chaudhary in Kolkata who is doing it, and for him, he is mandated pancreas with kidneys only. So for us, it's a wonderful news that we can only do pancreatic transplants. How many grafts can we get, because there are a lot of patients?
So that's the bottleneck always. The organ donation rates in India are getting better, but we're looking at about 500 donations a year pan-India, about 500, of which these are all comers. Our criteria to accept pancreas grafts are stringent because we don't want to have problems after transplantation. You can imagine pancreas, you get pancreatitis, you must have heard of pancreatitis. Pancreatitis is devastating. And to have pancreatitis in a patient who's had a transplant is even more devastating. So we are very strict in which organs we can accept. So coming to a follow-up question from you is, how can we then address the supply demand, correct? So with 500 patients or 500 donations, of which maybe 50% might be useful, so that's 250 grafts. But we're talking about thousands of patients. So what we're trying to do with MGM Healthcare is to develop the cellular basis of treating diabetes, which is what my goal is for 2030, is to cure diabetes, pancreas transplantation as a platform, and then move on to cellular medicine to be able to address that issue, where one pancreas graft may be able to treat 100 patients. So there's a paradigm shift in the equation. So that's work in progress.
Thank you, sir. Last but not the least, we did discuss that the candidature for a patient can be diabetes along with a kidney failure. But what about the other comorbidities? For example, a long-standing diabetes might be having a cardiac condition as well. So do we consider them as doable or not doable?
So right now, the international guidelines for isolated pancreas, they say that you have to have life-threatening hypoglycemic unawareness. I don't completely agree with that guideline, because sometimes you might have your diabetes making you blind, but you still feel when your blood sugars are going low. So what about these patients? Your patient has got cardiac problems because diabetes, but still understands when his blood sugars are going low and doesn't qualify for a pancreas transplant. So we're in the realms of trying to change those criteria. The reason those criteria came in because the expertise with pancreas transplant was restricted to very small centers. At Oxford, we demonstrated that we were doing 120 a year successfully. So we demonstrated from our data that this can be done successfully if you choose your recipient properly, you choose your donor right. And there are interventions you do after the transplant that Dr. Dinesh has introduced a lot of paradigm shifts in treatment of patients after transplant that keeps their graft away from pancreatitis. So now we're confident that we can actually do it without major morbidity in the patient. So this is the time to extend the indications. So your patient with your cardiac problems and diabetes should be a candidate for isolated pancreas.
Besides type 2 diabetes,
Genetic familial pancreatitis is called SPINK1 gene deletion. Young kids who have pancreatitis and repeated hospital admissions, and the only treatment is to take the pancreas out, and then they become brittle diabetics. It's not they're not type 1 diabetics. They've been surgeons have taken out their pancreas because of pancreatitis and because of gene deletion. That's another big cohort of people that may benefit from a pancreas, isolated pancreas transplant. People, the diabetologists around the world now are looking at these pumps that I alluded to, the closed loop systems, but the brittle diabetics do not do well with the closed loop system. Medtronic knows that. They don't want to release that data. But the only treatment for them is an isolated pancreas.
so these endoscopists have started doing this endoscopic duodenal resurfacing for type 2 diabetes, for the regrowth of beta cells.
So beta cells don't regrow. That's the problem. That's the problem we found when we were developing our cellular program. If beta cells regrow, we won't be talking about diabetes. We will be cured diabetes about 40 years ago. They don't. So the endoscopists who are resurfacing the duodenum are, I wish them all the best. The world's done that yet. And the reason is, the pancreas, it's a very shy organ. When you're taking it out from someone, cooling it down and warming it up, it causes what's called as post-reperfusion pancreatitis. We can control it, and we've demonstrated we can control the pancreatitis. But if you look at a kid, 5-year-old kid, it's got small vessels. The pancreas is like a sponge. It soaks up all the blood. So it's almost like the kid's going to have a blood loss because it's gone into the organ. And then you have pancreatitis. We haven't yet been brave enough to do it in kids. I've transplanted kids with a multi-visceral graft. That means it's got the liver, it's got the stomach, it's got the pancreas, it's got the small intestine. That's the only pancreas transplants we've done in kids.
So what's the age, sir? Maximum minimum age?
So the youngest I've done is a 15-year-old. But the doors are open for people to do younger kids.
Thank you.
If you look at 10-year survival, and the paper has just come out from Oxford, and there's another paper from Minneapolis. The 10-year survival is 87% of the graft, not the patient. That means in 10 years, 87% will still be free from diabetes. There's a 13% chance that you may need another pancreas transplant. And of that 13%, so if you look at 100 patients, 3% may need their pancreas to be taken out, so 3%, because of pancreatitis, and it's all loaded up right after the operation. Once you move away from that pancreatitis thing, in the first 6 weeks, you're on your own. You escape that bracket. So it's all front loaded with that effect of pancreatitis. 3%. It used to be 50%. We brought it down to 3%. Shall I? We've taken it to another level. I would, the indications, you guys can look up indications for intestinal transplants, all there on Dr. Google. But I'm going to talk about a very specific indication for intestinal transplant, and that is for cancers. And the cancers are 3 main cancers. One of them Steve Jobs had. Steve Jobs had a neuroendocrine tumor of the pancreas that metastasized to the liver. He got the original pancreas, head of the pancreas removed, almost a cure, 3 years later had metastases in the liver because it was almost a cure, not a cure. They had left some cells back and he had metastasis in the liver. And you can imagine Steve Jobs, I mean, can you imagine all the money in the world, but got the wrong transplant. They saw metastasis in the liver, they went and transplanted the liver, thinking job done for Steve Jobs. Guess what happened? The cells that transferred tumor into the liver were not taken care of. And they went back into the liver, they went back into his bones, and that was the final straw. So neuroendocrine tumors, it's a very special type of tumor. It can start in the pancreas, it can start in the intestine. Very slow growing, very, very slow growing. But once it starts the exponential growth, there's no control to it. So you've got to be able to do the right thing for the appropriate patient. Not every patient with neuroendocrine tumor needs a transplant. Let me just say that. You can take neuroendocrine tumors in small aliquots, resect it. It may come back, resect it. But once it starts going into the liver, then don't transplant the liver. That's not the right thing to do. You need to be able to take everything out from the abdominal cavity and transplant like for like. That's when you take out macroscopic disease. You're still left with a small portion of microscopic disease that be circulating in the blood. But our techniques now for post-transplant immunotherapy have gotten so good that we take care of those micro metastases. So I'm going to concentrate this talk on 3 tumors that can be cured by intestinal or multivisceral transplant. One is neuroendocrine tumors. The second is something called desmoid tumors. Now, desmoid tumors are fibrous tumors in the intestine that blocks the intestine, eats into the intestine, and patients are absolutely miserable. And it follows a genetic problem called FAP, familial adenopolysis. Can benefit from intestine, but today I'm going to concentrate on the tumor that arises from the appendix. It's a very rare tumor. You'll see 1 to 4 per million cases, and 80% of them will be treated by conventional therapy. The conventional therapy is called complete cytoreductive surgery and HIPEC. That is the conventional surgery. 80% will do well with that. 20% will come. And there's no future for this 20%. And I was involved, I engineered the first ever transplant for this indication 10 years ago in Oxford, and was heavily criticized for that transplant by world leaders who didn't believe in that process. Today, the patient's still alive. Should have been dead within 3 months. So the patients that come for this type of transplant are patients who have gone through every conventional operation that's possible. Their backs are against the wall, they are on TPN because they can't use their intestine. There's a tumor coming out of the abdominal wall, and they die a miserable death. They don't die because of metastases, they die because of obstruction from the tumor. It's locally advanced in the abdominal cavity. It erodes into blood vessels. They die of a bleed out, slow death, like you've opened up a vein in someone and they start bleeding. So there's no hope for these people, but there's hope with transplantation. I'm going to try and just quickly go through certain definitions and we can come to that. So intestinal failure, there are 3 types, type 1, 2, and 3. Type 1 is you go into the hospital, big operation done, your bowels are not moving, you're not being able to absorb, you're not being able to eat or drink. they give you temporary TPN. Within 30 days, it resolves, everything's good, everyone's happy. Type 2, if that doesn't resolve and the abdominal surgery has been really big, you could have catastrophes from that abdominal surgery and have multiple stomas, and it's a mess in the abdomen, and general surgeons are not interested in going back and trying to resect that. That's type 2 intestinal failure. This needs to go to a specialized center, which Dr. Dinesh has created at MGM, called Intestinal Failure and Rehabilitation. These are the patients that are lying there in hospitals. Nothing can be done locally. We bring them into our center and rehabilitate them. How do we do it? We put in a line, we give them nutrition, get their nutrition good for them to start eating. And that may take up till a year. They don't have to be in the hospital, but they can be outside. We teach them how to do their nutrition, and they come back a year later, well, repleted nutritionally, and that's the time I go into that difficult abdomen and connect them without a transplant. That's type 2 intestinal failure. Then we come to type 3, where you've lost your intestine, irreversible loss. There's no way you're going to survive unless you get lifelong TPN, or in India, which that is not a possibility because of cost restraints, you get a transplant. So type 3 is the only one that I would recommend needs to go for a transplant. There are no numbers right now, but there's some numbers that we can get from extrapolate these numbers from the UK, Europe, and USA. So we look at the point prevalence of intestinal failure requiring TPN, all comers, type 1, type 2, type 3, is about 1260 patients per year. So UK population is about 70 million at 18 patients per million per year. So we extrapolate that to type 2. So of these, most of them are going to be okay after 30 days. Of 14.6 patients per million will slip into type 2 intestinal failure. And we're talking about roughly about 100 patients a year. So small numbers that will have irreversible intestinal failure. These are the 3 types that we talked about. Again, this is the NC Pod report in 2010 that allowed us to believe that there is a need for intestinal rehabilitation centers. And this is when we started the program in the UK. Mostly are post-surgical complications. They are in the general ward. No one wants to deal with them. These are the patients that we would take on board and rehabilitate them. So there's the AGA guidelines. They've been about 25 years. Impending or overt liver failure because of TPN, you need a transplant. You get thrombosis of the veins because the TPN is going through the vein, you need a transplant. And access-related sepsis, you need a transplant. However, we've changed that because we've gotten better at intestinal transplants. We've moved the indications, and I said the first transplant for pseudomyxoma of the appendix, cancer of the appendix, was done by me in 2012. So is there an association between intestinal transplant and cancer? Can we really do it? So which ones qualify? We talked about neuroendocrine tumors, desmoids, and the last one I'm going to talk about is PMP, pseudomyxoma peritoni. The characteristics of this tumor are peculiar for this disease. Slow growing, it's central disease. It encases the intestine and it obstructs the intestine, and they get nutritional failure. And sometimes the disease comes out of the abdominal wall, and they get abdominal wall failure. Usually appendicular in origin. There are ovarian PMPs also. There are gastric PMPs. We've limited our first step to appendicular PMP. They fail conventional therapy, they've obstructed bowels, but they have to have disease that's limited to the abdomen. The ground rules, we look at biology, we look at geography, and look at the therapy. So biology, it really doesn't matter right now. It could be high grade or low grade. We're taking all comers. geography is important, that disease process has to be limited to the abdominal cavity. And in therapy, there should be no other conventional therapy available, and then they come to me. If there is conventional therapy, I will say no. Go ahead and get your conventional therapy done, because 80% of the times you do well. And my 3 A's, my aim, have maximum clearance. That this patient's clip will come up. It's the first ever multivisceral transplant for this indication. So the biology is usually low grade, but can have high grade variants. But radical surgery to decrease tumor burden is the only valid option. This is the appendix with that. Can you see the jelly-like material coming out? So that is what happens. It's called a jelly belly. That's the street name for this disease, a jelly belly, because this is what it looks like. There's only jelly in the belly. The CT scan looks frightening. This is all tumor, you see. There's a normal liver sitting there, but everything else is tumor. You see the tumor coming out of the abdominal wall. These people have no eruption. This is tumor. This is cancer coming out of this abdominal wall. You can see this is the last case I did before coming here. You can see the tumor coming out of the midline incision that was used to do complete CRS on him a few years ago. But he's past that no one will treat this. This is the burden of the disease. You can see the jelly there on the right hand side. As I said, abdominal wall failure. You're picking out tumor as it comes out of the abdominal wall. So this is the first case we did in Oxford. The same case I showed you in the first slide with that tumor coming out of his sternum. This is how we planned the incision. And we achieved maximum clearance. There's nothing left in the abdominal cavity. We took everything out. Nothing left. Everything taken out. Here we've left the liver, because the liver didn't have to come out, but everything else is out. You can see the kidneys bare, and the blood supply to the liver is preserved. That's the bad option. But everything else is taken out. This is as radical as you can get. This is my preparation to put in the new graft, and my ability to replace like for like. The organs that I can replace an isolated intestinal graft, I can do a modified multivisceral graft, I can do a full multivisceral, and I replace the abdominal wall too, where people have abdominal wall failure. So this is what an isolated intestinal transplant requires. That's the graft that I transplant in pink. Everything else is native. This is a bigger graft. You can see the stomach is there in the graft. It's called a modified multivisceral. But the liver is the patient's own liver. And we connect the graft into the liver. And this is a multivisceral transplant where everything is transplanted. The liver, the stomach, the pancreatic complex, the small bowel, and the large bowel. And the advantages of multivisceral transplant, it's like the cluster of grapes theory. You try it at home, you buy a cluster of grapes, and you keep the grapes as one, buy another cluster and take all the grapes out and keep it separately. You will see that the cluster of grapes lasts longer. Individual grapes will get softer very quickly. So the same theory here, one blood supply to all the organs. This is an example of an abdominal wall transplant. The abdominal wall is got from the same donor from which you get the intestine. And the abdominal wall has the skin, the subcutaneous tissue, the muscles, and the peritoneal layer. So this is what we did. We took out all that and created that with the abdominal wall transplant. This is the ability to replace like for like. This guy didn't need an abdominal wall transplant. I closed him primarily. So you can see the hole that's been made, and my ability to transplant the abdominal wall closes the hole. This is the organs that I take out. This is the organs on the back table that cooled down. And those are the organs I put back in. So I've restored physiology and anatomy to the abdominal cavity. This is an example of an abdominal wall transplant. I was worried about the abdominal wall being in ice for too long. So I put it on the patient's forearm to get a blood supply till I can get the organs out and take my time taking the organs out. And you bring, this is one of the oldest tricks described by an Indian surgeon, Sushruta, thousands of years ago, borrowing blood supply from a different area and attaching it to the abdominal wall. And using that skin as a monitor on the patient's forearm. So that skin becomes a canvas to the immune temperature of the body. If the immune temperature rises and is going to attack foreign, it attacks the skin first. If you don't treat the skin, 15 days later it'll attack the inside organ. And this concept now is used by heart and lung people, they're used by abdominal organ people, they're used by pancreas transplant people. It's become a worldwide phenomenon. This is what I use. I take a small skin graft from the same donor, cadaveric donor. It's got a blood supply. I put it onto the forearm of our recipients. And that's how it looks like. This is your monitor. Today, no rash. It's a fantastic day. Don't call the doctor. You don't need the doctor. If you see a rash, take a picture, send it to your doctor. You need to come in, get a biopsy of the rash, and treat the rejection. The rash is a rejection. Immune temperature is raised. It's identified the skin. It hasn't yet identified the intestine or any of the internal organs. You treat this, the internal organs are never attacked. This is a phenomenon that we've written many, many times, and multiple colleagues around the world now using this. So this is a method of remote patient-led immune monitoring. For her, the skin graft is her abdominal wall. The abdominal wall's got the same skin that you put. So she didn't need a forearm flap. She got an abdominal wall transplant, and she would send me a picture saying, "My wall looks good today, and things are good." So the patients get confidence that they are in charge of their post-op affects. So restore anatomy and physiology. This is the left side is a cancer, the right side is normal, absolutely normal. All new things have problems. We're trying to solve these problems. Rejection was not a problem because we're using the forearm flap. We look at recurrence, looking at graft-versus-host disease because the amount of tissue we transplant can attack the host. And we have unique methods now to be able to deal with that. This complete site reduction. So the answer that's appearing now over 10 years, that yes, you can transplant for cancer. And the first organ that we're looking at, and the first disease process we're looking at is neuroendocrine tumors with metastasis to the liver. The second is desmoid tumors with the familial adenopolyposis syndrome. And the third kid on the block now is appendiceal cancers that have spread in the abdominal cavity. It's called pseudomyxoma. We've learned lessons, there are challenges. Is there evidence for it? And the evidence is not yet there. I mean, we've got only 21 patients transplanted, but the evidence is mounting. And I'll leave you with this slide by Thomas Starzl, who did the first ever successful liver transplant. And I follow these words quite closely to my heart. The distinction between creative and delusional thinking usually becomes clear only in retrospect. This was my mantra when people were attacking me when I first did the transplant for appendicitis cancer. And so usually it's cadaveric for adults to adults. You can do living donor from adults to pediatrics because the length that you require for an adult is a bit different from the length you require for pediatrics.
Adult and give it to the other adult that way.
Like a liver transplant. It is possible. Anything and everything is possible. However, it will be possible once many centers start doing intestinal transplants. That means that bottleneck that we have for pancreas starts appearing as a problem. Right now, it's not a problem. Right now, we still have 500 intestines, and we've got 10 patients on the list. So there's no requirement to actually innovate.
But in case we don't have a matching donor cadaver,
You can keep people alive on TPN. It's like your dialysis in kidney failure. That is a specialty on its own, which Dr. Dinesh has mastered. You can keep patients alive. They're doing well on TPN. So to risk another adult's intestine for that and not being able to wait for an appropriate donor, I think it's right now it's far-fetched. But in time, it will become the norm.
last question, sir. We discussed about a diseased body in which we are doing a transplant. What about traumatic bodies? So people who have met accidents and things like this, is it possible for them as well?
So most of our deceased donors are trauma victims, but have been successfully transported to a hospital where they are brain dead, but their hearts are still beating, and these are the traumatic patients that we're talking about. But if you see a patient's dead on arrival at a hospital due to trauma, that would not be an organ donor.
Thank you.
Therapy is now very sophisticated. And the Swedish guys have shown that if you get colon cancer in the liver, you cure the primary by taking it out, but you then, if you can transplant these livers and the colon cancer doesn't come back. But there are certain criteria for that.
They went for the liver transplant, but the liver was completely damaged.
So that's a different reason for unfortunate demise of your patient. It wasn't because of the cancer, it was because of the liver that didn't work. It's coming up. It is the future. My very close colleague, Joe Tector, he's now at the University of Miami. He's one step away from using xenotransplants, but he's been working on it for 25 years.
So after listening to such a mesmerizing talk, I can only say you are living the dream of Dr. Thomas Tals, who is a burden of genius. Thank you so much, sir.
Thank you very much.
So whatever the pictures you showed ना ऐसे लग रहा है जैसे यहाँ से निकाल के सब कुछ निकाल दिया और नया भर दिया उसके.
It's like going to a car workshop, opening the hood, opening the hood and replacing the engine.
The cancer goes beyond the intestinal. And what would be the eligibility criteria?
Please rephrase that question. I didn't understand.
The cancer.
During the patient. Ridicule of your classmates as you're going through the schooling system. Tell them there is options here. There is live donor kidney transplant. You go through a normal teenage year, and the system that we have in place will make sure there's a transition into adulthood. So it's a holistic, it's an ecosystem that we've created that'll help these kids get transplanted earlier and lead as normal a life as possible. So that's number one. There's pediatric live donor kidney transplant. Not many people are doing it. Not many centers in the world are doing it. Perhaps the biggest center is Great Ormond Street in London. The second one, pancreas transplants. There is donors in India, cadaveric donors, there are not many Indian patients now on the list. That will deplete itself once the popularity increases in India, then the law suggests that you have to transplant Indian patients first and then foreign patients. And that's what happened to lung transplantation also. You know, the centers now have gotten very good at them. Indian patients are getting registered, and therefore the foreign patients are getting, you know, they're not getting the benefit from that. And that may happen to pancreas. Intestinal transplants, even the pediatrics, as well as adults, is still an untapped territory in the world. There are a few good centers in the United States. There's 2 centers in the UK. There's 2 centers in Europe. Nobody else does it. There was a patient in Singapore that had to take the team from Duke University from the US, take the whole team to Singapore and transplant in Singapore. So there is an open market for intestinal transplants, pediatric as well as adults.
At the back of your mind, if we get a patient who needs a pancreatic transplant, what should we do? How to go about? Whom to contact? What is the cost? For that, I would invite Mr. Harish Manian to come here on the dais. And if people have any question regarding the logistics of, bringing transplant patients to MGM Hospital Chennai, I think they can clarify their doubts here itself. Sir, please.